everyone, and welcome to AMCP's eLearning Day webinar titled Preventative Health in Action, Advancing Shingles Vaccination in Special Populations. Thank you for taking the time out of your day to join us. My name is Alexis Silva. I am a clinical advisor at Employers Health, and I'll be your moderator for today's webinar. This continuing pharmacy education session was designed to achieve the learning objectives listed on this slide. This session is supported by an independent medical education grant from GSK. And the financial relationships reported by the faculty for this session are shown on this slide. They're also available in your handout, which can be found in the Resources tab in Zoom. And all AMCP education must be conducted in a manner that avoids the fact or appearance of conduct which may violate antitrust laws. So please refer to the antitrust policy located at the website listed here. And it is now my pleasure to introduce our faculty for today's program, Drs. Abby Singleton and Victoria Wolf. Both are senior pharmacists from Highmark, and full faculty biographies can be found within the handout. So now we'll be beginning our presentation, and Abby, I will pass the floor over to you.
HZ is a painful skin eruption with dermatomal distribution caused by reactivation of latent varicella zoster virus, also known as VZV, which typically occurs years after primary VZV infection, either varicella or chickenpox. It is also referred to as shingles or zoster. Chickenpox and shingles are related because they are caused by the same virus, VZV. After a person recovers from chickenpox, the virus stays dormant or inactive in the body, and it can reactivate years later and cause shingles. This leads to a development of a painful vesicular rash and can cause complications such as post-herpetic neuralgia and vision loss. When thinking about the incidence, next slide. HZ can occur at any age in persons previously infected with VZV. It is most common in adults greater than 6 years of age with age-related immune decline. The annual incidence is about 1 to 3 per 1,000 person years in individuals less than 50 years of age, and about a third of people will contract HZ in their lifetime. And it's also estimated that about 1 million cases do occur annually in the United States. When thinking about the burden, HZ is a painful infectious neurocutaneous disease. In its early stages, HZ is typically foreshadowed by prodromal symptoms such as pruritus, numbness and tingling, and or pain in a unilateral dermatomal pain pattern, which evolves into a painful vesicular rash that lasts a variable amount of time. While rarely lethal, a mortality rate of about 0.28 to 0.69 cases per 1 million, HZ does cause significant morbidity as well as societal costs. And there are several complications associated with HZ, such as secondary infections, neurological adverse events, facial paralysis, stroke, and even ophthalmological adverse events. Then when thinking about the burden in immunocompromised patients, there are millions in the United States that are immunocompromised. About 7 million adults do self-report being immunosuppressed. And then there's estimates that about 3 million have HCT recipient patients with hematologic malignancies, renal or other solid organ transplant recipient patients, patients with solid tumor malignancies, and people living with HIV. In addition to these groups, there are approximately 22 million with one or more than 80 diverse autoimmune and inflammatory conditions, such as lupus, rheumatoid arthritis, and inflammatory bowel disease. These patients often have underlying immune defects, but generally are not considered frankly immunocompromised unless they are on immunosuppressing treatments. Importantly, an increased proportion of immunocompromised patients are likely being treated with immunosuppressive therapies, and age-specific prevalence of immunocompromise is highly variable by condition. So with these patients too, it's important to keep in mind that complications are increased. They might have post-herpetic neuralgia or are more likely to have severe disease, and they are like 2 to 4 times have a higher fold risk of HZ as well. So you might be thinking with the childhood varicella vaccination that our rates of HZ would be decreasing. However, there have been studies that looked at this, and in one large study of 27 million persons over the age of 35 in the United States from 1993 to 2006, the estimated incidence of HZ was 2.5 per 1,000 persons. In 1993, 6.1 per 1,000 persons, and up to 7.2 per 1,000 persons in 2016. There are several hypotheses that exist to explain why there has been this increase in incidence of HC over time. There is one theory that talks about exogenous boosting, which argues that the rise in HC incidence is related to the implementation of childhood varicella vaccination programs, which reduces exposure to wild-type VZV. Other countering perspectives argue that the incidence of HC was increasing even before the universal varicella vaccination implementation, and that other independent variables such as demographic changes, increased use of immunosuppressants, and increased health literacy and awareness around HC may be contributing to the increased rates of diagnosis and treatment. So the incidence and severity of HC, as well as the frequency and severity of its complications, do increase with age. Postherpetic neuralgia is typically zoster-associated pain persisting for at least 90 days. Overall, 10% of all patients with HC experience one or more non-pain complications, such as ocular and neurological complications or skin superinfections. Some studies have found that HC resulted in 2.1 hospitalizations per 100,000 patient years. This number encompasses hospitalization for HC across all age groups. However, hospitalization was far more common among adults aged 60 years and older compared to those aged 25 through 59 years of age. There have also been a couple US studies that have showed significant incremental health care use during the acute and subacute HC period among patients in the managed care setting. Cost estimates in these studies do range from $431 to $605, with most of the cost burden caused by outpatient care and prescription drug costs. When thinking about the economic impact of HC, one study looking at this impact used a patient-level microsimulation model that projected health and economic outcomes among US adults aged 18 years or older using a 10-year time horizon. A comprehensive systemic literature review was conducted to generate parametric values and conducted simulation modeling to generate outcomes, including the number of cases of uncomplicated HC, postherpetic neuralgia, and ocular complications, productivity losses, and quality-adjusted life years. A societal perspective was used for outcomes, and the costing year was 2015. They did project about 1.1 million HC cases, with 114,000 postherpetic neuralgia cases, with 43,000 ocular complications, and they estimated total cost to be exceeding $2.4 billion, with total quality adjusted life years loss of 67,000 per year. So as we know, we have a very effective shingles vaccine that is now available. There is a large burden of HC that can be alleviated through strategies by managed care professionals. The elderly and immunocompromised individuals are especially impacted, and there is an increased risk of incidence and severity in both the elderly and immunocompromised groups of patients. So now going into the guidelines and clinical considerations, RZV is a 2-dose subunit vaccine. It is supplied in 2 presentations, a vial and vial presentation, as well as a pre-filled syringe presentation. The vial and vial presentation does not require reconstitution, or does require reconstitution, while the pre-filled syringe does not. This pre-filled syringe was recently approved by the FDA on June 17th, 2025. I did reach out to the manufacturer, and they're expecting it to launch in early 2026. And then looking at what the CDC recommendations are for RZV, they recommend it in prevention of HZ in adults 50 years of age or older who have had shingles, received zoster vaccine live, or received the varicella vaccine. They also recommend it in adults ages 19 years or older who are or will be at an increased risk of HZ due to immunodeficiency or immunosuppression caused by any known disease or therapy. And of note, ZVL is contraindicated in immunosuppression and immunodeficiency. So because these were contraindications for the previously available zoster vaccine, and the recombinant zoster vaccine was originally recommended for immunocompetent adults aged 50 years and older, there has been an unmet need for vaccination against herpes zoster in immunocompromised adults. So 2 RZV doses are necessary regardless of the previous history of herpes zoster or previous receipt of zoster vaccine live. The second RZV dose should typically be given 2 to 6 months after the first. For persons who are or will be immunodeficient or immunosuppressed and who would benefit from a shorter vaccination schedule, the second dose can be administered 1 to 2 months after the first. If the second dose is given sooner than 4 weeks after the first, a valid second dose should be repeated at least 4 weeks after the dose given too early. The vaccine series does not need to be restarted if more than 6 months have elapsed since the first dose. When possible, patients should be vaccinated before becoming immunosuppressed. Otherwise, providers should consider timing of the vaccination when the immune response is more likely to be robust. So, for example, times of lower immunosuppression, or if a patient is having stable disease. RZV may be administered to patients who previously received the varicella vaccine, and it is not a live vaccine. Therefore, it can be administered while patients are taking antiviral medications. It's also been found that concomitant administration of RZV with other adult vaccines has been studied, and there is no evidence for interference in the immune response to either vaccine or safety concerns. The CDC does also have timing considerations for special populations. It's really important that the vaccine timing and schedule should be tailored to each patient's specific situation, considering factors like type of transplant, the level of immunosuppression, and the timing of antiviral therapy. They do recommend for HCT recipients for autologous HCT to administer RZV at least 3 to 12 months after transplantation. And then for allogenic HCT, administer RZV at least 6 to 12 months after transplantation. And then for both, depending on the time of discontinuation of antiviral therapy, vaccination prior to discontinuation of antiviral therapy is preferred. And for timing of solid organ transplant recipients, when possible, you should administer RZV prior to transplantation. If this is not possible, you could consider administering it 6 to 12 months after transplantation, preferably at a time of stable graft function and on maintenance immunosuppression. And for patients with cancer, when possible, administer RZV prior to chemotherapy, treatment with immunosuppressive medications, radiation therapy, or splenectomy. If vaccination prior to chemotherapy, treatment with immunosuppressive medications, radiotherapy, or splenectomy is not possible, administer RZV when the immune system is no longer acutely suppressed, or for patients receiving continuous immunosuppressive therapies when the immune response is more likely to be robust. And then for patients receiving anti-B cell therapies like rituximab, you could consider administering a dose approximately 4 weeks prior to the next scheduled therapy. There's also recommendations for patients living with HIV and autoimmune and inflammatory conditions. For those with HIV, antiretroviral treatment for HIV may improve immune response to vaccination. While greater immunogenicity has been seen in the setting of viral suppression or higher CD4 counts in some vaccines, administration of unvaccinated or recombinant vaccines do not need to be delayed if these criteria have not been met, especially if that would lead to a significant delay of vaccine administration. Patients with advanced HIV should receive RZV because the risk of shingles is further increased in the setting of such immune compromise. And then for those with autoimmune and inflammatory conditions, vaccination should optimally occur in the setting of well-controlled autoimmune and inflammatory diseases, and when possible, administer prior to initiation of immunosuppressive medications. If vaccination prior to the initiation of these medications is not possible, you could consider administering RZV when immunosuppression is anticipated to be low. Of note too, NCCN also has some of their own recommendations for RZV. Once again, like we talked about, just making sure this is being tailored to each patient. But they do recommend vaccination for prevention of HC in adults 50 years and older, and then also for patients age 18 years of age or older who are or will be at increased risk of HC. And then for patients who previously received ZVL, RZV should be given 2 months after the last dose of ZVL. For timing, the recombinant zoster vaccine should be given to patients about 50 to 70 days after autologous HCT, and RZV could be considered after allogenic HCT, but according to NCCN, its efficacy in allogenic HCT in the presence of GVHD or during ongoing immunosuppression has really not been established. So once again, just making sure we're tailoring these recommendations to each patient. So when thinking about vaccine efficacy in immunocompromised groups, Estimates of vaccine efficacy have come from 3 studies, with vaccine efficacy of 68.2% for autologous hematopoietic cell transplant recipients and 87.2% and 90.5% in post-hoc efficacy analysis for patients with hematologic malignancies and potential immune-mediated diseases, respectively. Overall rates of serious adverse events were comparable between RZV and placebo recipients. Serious adverse events deemed to be related to vaccination by study investigators range from 0 to 1.6 in the RZV group and 0 to 7.76 in the placebo group. So in addition to the critical outcomes like prevention of herpes, zoster, and serious adverse events, other outcomes have been evaluated. One study among hematopoietic cell transplant recipients reported vaccine efficacy of 89% for the prevention of post-herpetic neuralgia and 85% for prevention of herpes zoster-related hospitalization. Immune-mediated diseases were evaluated in 6 studies and 5 immunocompromised groups and were not increased among RZV recipients. One study in patients with hematologic malignancies reported on graft versus host disease among hematopoietic cell transplant patients and did not identify an increased risk among RZV recipients. One study among renal transplant patients reported on graft rejection and did not identify an increased risk among RZV recipients as well. So when thinking about what the pharmacist's role in vaccination is, pharmacists are very knowledgeable and accessible in nearly every community. We can help to expand access to care and improve outcomes. We are very much also known as trusted healthcare professionals that can provide education and counseling while also screening for eligible and high-risk populations. And this doesn't always have to be done just in the community, but as managed care organizations, we can do this through our MTMs and with our population health teams as well. We can also help to promote awareness and administer vaccinations on site, which helps provide convenience for patients and also collaborate with other healthcare professionals. So now I'm going to pass it off to Dr. Wolf to go over treatment gaps.
Thank you, Abby. So when we're thinking about treatment gaps and the potential for individuals to miss out on this herpes zoster vaccine, there are 2 points in time we really look at here. The first is the failure to receive the vaccine initially, and the second is the failure to complete the vaccine series. We have a lot more data on failure to complete series than we do on receiving that initial vaccination. But we are able to make some inferences and conclusions about special populations and their ability to access this vaccine. So when we think about general uptake of the vaccinations, so looking at that first point in time, where individuals would receive that first dose, some of the most robust data that's available comes out of the CDC. So the CDC has a national health interview survey that they conducted in 2020, and they looked at adults over 60 years old. So granted, this isn't our population of immunocompromised folks that are typically under 60 that we're thinking about, but this does give us a baseline for our future kind of statistics and analysis we're going to discuss. So in adults over 60 years old, in 2008, less than 7% had ever been vaccinated, but in 2018, that jumped to 33% ever vaccinated. So you can see there's a large jump there. And now the CDC also looks at some demographic characteristics of those who receive the vaccines. There was no difference in vaccination rates between men and women. However, there were differences based on race. So non-Hispanic white individuals were more likely to receive the vaccine, with just under 40% being vaccinated under 60, whereas Hispanic and non-Hispanic Black individuals were both under 20% for their vaccination rates. So quite a stark contrast there. Now, unfortunately, the CDC does not have data breaking down that kind of first point in time, that first vaccination uptake for our special populations. But there was one study that was interesting that I think we can use to discuss some patterns in vaccination. So one kind of unique group of patients would be from the VA, right? Because these patients are kind of embedded in a giant healthcare system, and there's lots of data available about these patients. So one cross-sectional study from the VA Quality Enhancement Research Initiative and the University of California, San Francisco, looked at veterans across over 130 facilities from January 2018 to June 2023. In that population, they had just over 23,000 veterans who were younger than 50 years old. Now, in this group of patients, so all 190,000 were prescribed at least one immunosuppressive medication for at least 90 days. In that study, what they saw was that the next slide, please. Thank you. The vaccination rates were um, were higher than those reported in the general population from the CDC for 60 years plus. But something important to keep in mind here is that these patients had established care, right? They're embedded in a healthcare system. So you can see here the lowest rate of any vaccination were individuals who had biologic monotherapy at 39%. And then the highest rate were those who are on the targeted synthetic disease modifying anti-rheumatic drugs or combo therapy at a 53% vaccination rate of any RZV. One other interesting thing from this study that we were able to see is that they looked at vaccination rates in this group of individuals who are younger than 50. So we assume based on guidelines, right, that those are individuals who are immunocompromised if they're receiving the RZV vaccine. And they looked at those vaccination rates before and after the expanded indication for RZV in immunocompromised adults in July of 2021. So before, less than 3% of their patients under 50 were vaccinated. And then after that expanded indication, 13.4% were vaccinated. Now, this compares to the rates for patients 50 and older. Before vaccination, about a third were vaccinated, and then, or I'm sorry, before the expanded indication, about a third were vaccinated, and then after, about half were vaccinated. So this is, it is lower, right? But again, we're thinking about the total population within the VA that would be immunocompromised. So when we think about the next point in time where there's opportunities to increase vaccination rates, it's in that completion of the vaccination series. So real world data from multiple studies that demonstrates that patients who received the first dose of vaccine, in those patients, 70% received the second dose within 6 months, and then 82 received the second dose within 12 months. Now, this data is higher than some other vaccines that have multiple doses, particularly hepatitis A and B. Those series completion rates were a bit lower, ranging between 25 and 65%, compared to this 70 and 80%. On the other hand, these vaccination rates are lower than pediatric vaccination series, which do have very high completion rates. So it kind of falls in the middle of what we would expect. Now, looking at some real world data for that completion of the vaccination series, there's a longitudinal retrospective pharmacy and medical claims-based study that looked at RZV completion rates and adherence with the recommended administration schedule. And they were evaluating factors influencing completion rates. Some of those factors include immunocompromised status. So the inclusion criteria are adults at least 50 years of age who filled an RZV prescription between October 2017 and September 2019. So it was a very large study with over 1 million participants who had pharmacy and claims data, and then another 1 million who had only medical claims data. What we saw in this study was that patients with cancer who were using an immunocompromising medication had a lower odds of completing the vaccination series compared to individuals without that immunocompromised status. So in the primary cohort of all individuals, 70% of people received that second dose of the vaccine by month 6. But only 60% of individuals with an immunocompromising condition completed the series. We can see that the most impacted here were transplant recipients with an odds ratio of 0.82. And then the least impacted were cancer patients using an IC medication at 0.95 odds ratio. So now that we've discussed some of the treatment gaps that exist, it's helpful to think about why those gaps are in place and why those barriers exist. And I think we can kind of bucket these barriers into 3 general groups. The first being provider knowledge about recommendations for using these vaccines. The second being patient access to these vaccines. And the third being cost of these vaccines. So when we start discussing knowledge, there have been a few web-based studies that survey providers, including 2 here that I have. One surveyed medical oncologists, and another surveyed primary care providers. And they were looking to see essentially what these providers' awareness was of the current ACIP recommendations. So in the medical oncologists, 2/3 surveyed were aware of all of the ACIP guidelines. And then in primary care providers, again, 2/3 correctly identified that individuals 19 years of age and older at increased risk for herpes zoster were indicated to receive RZV. So we can kind of imply here, right, if individuals are 18 years of age or older and increased risk for HCV, that's talking about our immunocompromised group. One other thing that was interesting in this study was that the primary care providers stated that key barriers to recommending the vaccines to adults were insufficient time to assess risk factors. I think this could be particularly impactful for our immunocompromised patients, as the decision whether or not to vaccinate them is going to be inherently based on risk factors. So these shorter appointment times with a lot to discuss could really impact that decision. The second barrier that has been quite impactful to members and to patients has been access to these medications. So there have been shortages of one of the main vaccines, the Shingles vaccine, and these shortages lasted from 2018 to 2021. That vaccine in particular requires 6 to 9 months to produce and involves a complex supply chain, which did limit access for patients during that time. Another period of time where vaccination rates were lower due to access was early in the COVID-19 pandemic, where individuals were hesitant to go into healthcare settings due to risk of infection. So data from the National Immunization Survey Child looked at impacts of COVID-19 on pediatric vaccination rates. And these vaccination rates declined by about anywhere from 2 to 7% during COVID. You could assume that this would may be particularly impactful for immunocompromised patients as well, as they may have been particularly concerned about going into healthcare settings and potentially contracting COVID-19 during that time. It's important to note that if we go back a slide, that shingles vaccination rates are higher in patients who have access to healthcare. In Virginia, there was a study that looked at shingles vaccination within, it was almost 20,000 individuals, and vaccination rates were higher in those who had health insurance and those who had primary care providers. The last barrier access wise that I think is important to consider are challenges with multi-dose vaccinations. One of the barriers that providers reported in these web-based surveys regarding multi-dose vaccination, essentially failing to complete the series, one of the barriers was the responsibility of scheduling. So this might sound simple, but there was often confusion between if it was the provider's role to schedule the follow-up appointment for the vaccine or if it was the patient's role. And so sometimes the patient would be waiting for the provider to outreach, and sometimes the provider would be assuming the patient would outreach, and then they wouldn't complete the multi-dose vaccination series. So something that certainly could be an easier fix there to increase series completion rates. Geographic location can be challenging, especially if people have to travel longer distances to receive their vaccine. And again, as we discussed above, access to health insurance. That can be particularly challenging with multi-dose vaccinations, especially if your insurance changes between the first and second doses of that series. Now, the last barrier I want to discuss is cost. So when we think about cost of vaccines, often, you might think, oh, these vaccines they're cheap, right? They're $0 copays, but there's some caveats there. So Medicare Part D does cover these vaccines at a $0 copay, but there are considerable challenges for long-term care facilities who are looking to provide these vaccines to their residents. So for Medicare Part A, there is no additional reimbursement for any vaccinations. It's all kind of lumped into the per diem that Medicare pays out according to their prospective payment system. So at least at that immediate point in time, it could be seen as a financial disincentive where the facility would be paying to vaccinate a patient and they wouldn't receive additional reimbursement. Part D reimbursement can also be quite cumbersome for long-term care facilities, and oftentimes they will partner with a long-term care pharmacy to help with adjudicating and submitting those Part D claims. Medicaid usually covers RZV at a $0 copay. And then private health insurance plans are required to cover this vaccine at a $0 copay. And this requirement was enacted with the Affordable Care Act in 2010 regarding preventative vaccines at $0 copays. Again, there are caveats here. This only applies when patients are in network. And one really important consideration is most of these requirements are contingent on ACIP recommendations. And specifically, the private health insurance requirements are contingent on ACIP recommendations that are adopted by the CDC director. Now, in this political landscape, there has been some instability within ACIP and the recommendations that they may be able to provide. So if these recommendations change, that would potentially remove the mandate to cover these insurance or these vaccines at a $0 copay. So this is something to certainly keep an eye on if these recommendations change. Insurance plans will essentially have to decide on their own whether to cover these with a $0 copay or not. Finally, uninsured patients face quite a high cost of these medications. The cost of the full series ranges from $300 to $500. So now that we've looked at efficacy of these vaccines, we've looked at current guidelines. If we go to the next slide, we've established that there's a need to treat, right? That there are treatment gaps within this population, both at the initial point in time of receiving the vaccine and completing the vaccination series. I think another thing that is important for managed care organizations to consider are cost and effectiveness of these vaccinations. There have been two studies looking at cost effectiveness of these vaccines. Next slide, please. The first looked at adults 19 to 49 who had HCT, and then there were other groups as well, so HIV, breast cancer, Hodgkin's lymphoma, or renal transplant. They did a Markov model with a 1-year cycle length, a 30-year time horizon, and a willingness to pay threshold of $100,000 per year. And they found that in all disease states, HCV vaccination or RZV vaccination was either cost saving or within that willingness to pay threshold. The second study found the same thing. Now, they looked at slightly different disease states that fall under that immunocompromising condition. But again, all with the exception of autoimmune or inflammatory conditions were under that willingness to pay threshold of $100,000 per year or were cost savings. Now, the last thing that I think is important to talk about from a cost and also an adherence perspective is looking at the value of the pharmacy benefit in adherence to these vaccines. So, in one study, the authors had found that series completion rates for RSV vaccines were significantly higher in patients who received their first vaccination from a pharmacy or through their pharmacy benefit compared to those who received it through their medical benefit. So assuming that they went to, a provider's office. That difference was an 84% completion rate by month 12 when received by a pharmacy compared to a 65% completion rate when received through the medical benefit. Additionally, costs are about 25% lower for vaccinations distributed by pharmacies compared to those office-based vaccinations. So I think this is kind of a win-win-win scenario where the drug may be cheaper. It seems like an easy way to increase adherence rates and get that series completion for a cost-effective medication through strategies within the pharmacy benefit. With that, I'm going to pass it back to Abby to talk about some of those strategies.
Thanks, Victoria. So one study, the authors had this really powerful message in it that said pharmacists can act as educators, advocates, facilitators, and immunizers in the movement to vaccinate more Americans against vaccine preventable diseases. They did perform a study that was a prospective interventional study with a pre-post design that included 3 independent pharmacies across the state of Tennessee. These 3 pharmacies served populations that represented suburban, semi-rural, and rural demographics. They utilized both collaborative agreements with local physicians as well as prescriptions. During the intervention period, a one-time newspaper press release regarding the vaccine was published as a news item in local newspapers. This press release contained information about HC infection and the HC vaccination, including indications, side effects, and contraindications. Second, every prescription dispensed during the intervention period at any study site pharmacy contained a flyer advertisement, which contained identical information as the press release. Third, all current pharmacy profiles of patients with the CDC ACIP recommended indications for HC vaccine were identified as potential recipients. These patients did receive a one-time personalized letter via the mail, and this letter contained identical information as the press release and flyer. Of all the pharmacy-driven interventions, the personalized letter was found to be more effective than all of the other interventions in influencing patients to receive the HC vaccine. And they did find that vaccine rates did increase significantly with pharmacy-driven interventions. Another study that was a retrospective cohort design study was used to evaluate whether or not patients who had a pharmacist phone call or intervention were more likely to return for their second RSV dose than patients who did not have a pharmacist call intervention. The pharmacy chain where the study took place implemented a chain-wide call list in early 2018 to assist stores in reminding patients when it was time for their second dose. The pharmacists were provided a script that initiated the patient conversation. Of the 271 patients that were included, 69 patients received the phone call intervention from a pharmacist, where 63.8% of patients returned for their second dose. And of those who did not receive a phone call, 46% returned for their second dose. So they did find that this pharmacist phone call and return for second dose was statistically significant. It's also important that we recognize there are unfortunately racial and ethnic disparities regarding vaccination. The majority of studies that have looked at this have been in HPV, shingles, and the influenza vaccination. Hispanic and Black individuals are unfortunately less likely to be knowledgeable of vaccines, so making sure that these patients are getting equal counseling and making sure that they're knowing the benefits of these vaccines is really vital. Also, there's differences in attitudes towards vaccination and preventative care. And unfortunately, there's also variations in likelihood that providers may or may not recommend vaccinations based on certain racial and ethnic disparities. Like Victoria mentioned too as well, there are different social and health inequalities like poverty and limited access to care that can affect vaccination rates. And then there's also differences in concerns about vaccination. and differences in health insurance coverage for patients. So there was a really interesting study that was done during the COVID-19 pandemic. However, I think a lot of this information can be applicable to other vaccines. One managed care organization found it to be effective regarding the COVID-19 vaccine was data sharing and advocacy, where the managed care organization shared unvaccinated patients with retail pharmacists, where the pharmacist had a pre-existing relationship with the patient. The pharmacist then used this information to conduct targeted outreach to those patients. And the managed care organization also targeted vaccine deserts or zip codes with proportionally low vaccination rates. And they worked with the retail pharmacist to intervene with the unvaccinated patients. Internal programs that were shown to be effective included texting outreach, rapid response teams, and vaccine education to community-based organizations. In the texting interventions, the managed care organization would send a text to targeted culturally specific members, as well as those who were at a greater risk of COVID-19. This text did explain their eligibility and how they could go about obtaining the vaccine. In the case of the rapid response team, the managed care organization staff conducted telephonic outreach to unvaccinated members, providing education and encouragement to become vaccinated. And finally, the managed care organization worked with community-based organizations to provide live education, aiming to remove barriers to vaccine, such as misconception and misinformation. These strategies were associated with an increase in COVID-19 vaccine rates and showed the impact that the partnership between pharmacists in the community and managed care settings can have on individual and community health. Their conclusion was that clinical pharmacists are an untapped resource in the fight against health disparities, and they are embedded and interact on a regular basis with patients managing chronic conditions. Managed care pharmacists have access to population-wide data to identify gaps in care and mobilize resources to proactively address disparities within their communities. So as we know, education is vital to improving any disease state. And as managed care organizations, we can utilize our own staff for educational outreach to patients and also help support their community pharmacists by providing resources. It's also important to help identify and address barriers to vaccination, like we talked about, different racial and ethnic disparities, as well as differences in concerns that patients may have. And then it's also important to leverage consistent messaging. And unfortunately, as we know, there's a lot of confusing messages that are coming like from the government and public health agencies right now. So as professionals, making sure that we're still advocating and giving out information that is evidence-based to patients is vital right now. And then when thinking about vaccine hesitancy, unfortunately, there is much mistrust regarding government institutions and programs, especially new ones, and this is more common in those minority communities. Trust really needs to be earned over time and does require an investment and effort. Trust in our general society and in the healthcare delivery system is derived from several different sources, from personal experiences, or if they have a family member or have a community observation, and then also media representation. So building a rapport with your local community to share education information will further establish trust in both the pharmacist and the vaccine to ensure higher vaccine rates. So to optimize shingle vaccine coverage and improve health outcomes, payers should really consider several key factors: promoting equitable access and cost-effective through targeted utilization management strategies, also proactively forecasting and projecting savings by decreased healthcare resource utilization, staying informed regarding recommendation and guideline updates, being proactive and adaptable while utilizing continuing education, and also maximizing those relationships with manufacturers that have a lot of resources and can also help with some of these things also. So in conclusion, HZ is a common virus, and those who are immunosuppressed are at an increased risk of severe disease and long-term complications. There is a need to increase HZ vaccination rates in immunocompromised patients, and managed care professionals play a key role in reducing the health and economic burden of HZ through proactive prevention and management strategies. And finally, vaccination against HZ can significantly reduce disease-related morbidity and has been shown to be a cost-effective prevention strategy.
So that concludes our presentation. I will pass it back to Alexis.
Yeah, thank you, Abby and Victoria, for the great presentation. And we'll now open the floor up for any questions you might have. So you may submit a question or comment by typing it in the Q&A section at the bottom of the screen. And just as a reminder, please refer to your handout or the course instructions in the AMCP Learn for information on claiming credit. For our first question, what are the key safety and efficacy considerations for administering recombinant zoster vaccine in patients undergoing active chemotherapy or post-transplant recovery?
I'm happy to take that question, Victoria. So like we talked about, this vaccine is still shown to be very efficacious in our immunosuppressed population, not only for preventing RZV, but also preventing complications and hospitalization, which is huge because that morbidity factor can be so high in the HC population. So there is some good data that does really support both the safety and the efficacy, showing the adverse effects are also very low in these patients, and it doesn't interact with other vaccinations that these patients may need as well.
Thank you. And I know this is something that I'm particularly interested in hearing both of your answers on. I know as you were talking through some of the demographic specific information too, I was brainstorming some strategies that we can do from my end. So what strategies have been most successful in improving shingles vaccines access while still maintaining the cost effectiveness?
Yeah, I'll take a start with this one. I think some of the programs that we've seen to be most effective, Abby had discussed a few of them, but are really when we look at targeted pharmacist interventions, patients do really seem to respond better to individual outreaches that are tailored to their needs and to their specific health state. And when you look at that combined with using the pharmacy benefit, right? That can be particularly cost effective where vaccine costs can be lower. And again, people are more likely to complete that vaccination series. So I think that's kind of a unique spot that managed care organizations can target.
Yeah, I definitely agree with you, Victoria. I think also as managed care pharmacists, just making sure these vaccines are accessible and affordable to patients. One thing that's, I hope to see in the near future is, especially for the Medicare population, it can be very confusing which vaccine is covered under what part. Even both of my parents are pharmacists, and they will call me because they're confused about, where do I go and get this? So it would be amazing if we could get vaccines more standard coverage under Part B and D, and even like Victoria talked about Part A. So this makes it more accessible to patients and less confusing also.
Absolutely. And I know even just some of our materials internally as well have been in English. And so when you brought up the disparities that exist there, I think there is some room there for growth in education.
Yes, I definitely agree, Alexis. It would be, I wish I was multilingual, but I'm not. But to have, some multilingual healthcare professionals reaching out to some of these patients, I think would be amazing as well.
Absolutely. Well, that is all of the questions that we have today, but we do appreciate all of you that have submitted questions, and this concludes today's webinar. So thank you again for being here, and we look forward to seeing you guys at the next one.